give you some information about Ebola. You've got a lot of information, but this is just relevant information in relation to contact tracing, looking at definitions that are relevant to contact tracing, risk assessment of contacts, monitoring of contacts, and the trigger for investigation of contacts. But firstly, I just want to talk a little bit about, I suppose, the huge media interest that there's been in the Ebola outbreak, and the fact that in some countries this outbreak has been somewhat politicised, and that has generated understandable fear among the public. But just to say, a lot of that fear is unfounded, but has to be acknowledged. The following information, definitions and guidance are based on what we currently know about Ebola, but there may be new evidence or there may be new experiences from dealing with it on the ground, so these definitions and guidance may change. So relevant information on Ebola is relevant to contact tracing. There's a long incubation period, up to 21 days. Only symptomatic persons can transmit EVD. Transmission is based on direct contact of exposed mucous membranes or non-intact skin with body or body fluids of a person with EVD. There is no evidence of airborne transmission, and persons with EVD are more infectious at the later stage of illness. So the purpose of contact tracing is to monitor those who have been in contact with EVD in order to ensure early detection so that these people can receive early treatment, and also to prevent onward transmission. In Ireland, immediately after a case is confirmed, contact tracing will be initiated. So our current definition of contact is a contact who is an asymptomatic person who has been exposed in the previous 21 days to a symptomatic infected person or to a symptomatic infected person's secretions, excretions or tissues, which could include laboratory specimens, soiled environment or contact with infected human remains. The next stage is to look at somebody's exposure risk. And the current definition of high-risk exposure is somebody with close face-to-face contact without appropriate PPE with a probable or confirmed case who is coughing, vomiting, bleeding, or who has had diarrhea. Direct contact with body fluids or any material soiled by body fluids with a probable or confirmed case. Percutaneous injury, for example with needle, or mucosal exposure including mouth-to-mouth kissing, to body fluids, tissues, or laboratory specimens of symptomatic or probable or confirmed case. Participation in autopsy, resuscitation, or funeral rites with direct contact with human remains, including body fluids in or from affected areas without appropriate PPE, has had unprotected sexual contact with a case within 3 months after the case is recovered from EVD, direct contact with bush meat, bats or primates, living or dead in or from affected areas. Examples of low-risk exposure would be somebody with close face-to-face or physical contact, including skin-to-skin contact, such as hugging or shaking hands, with a symptomatic case who has no coughing, vomiting, bleeding or diarrhea. A household contact of a symptomatic case, and other settings such as the classroom or an office room contact would be subject to risk assessment. Also, casual or physical contact with a feverish but ambulant and self-caring EVD case, such as sharing seating area including airport transport, reception tasks, etc., get risk assessment. Healthcare workers with occupational exposure. Occupational exposure, including of a healthcare worker, including laboratory workers involved in caring for a confirmed case, or those dealing with contaminated or possibly contaminated inanimate objects, whilst using appropriate PPE, is considered to be a low-risk exposure. However, given the continuous nature of the occupational exposure involved in caring for a case, healthcare workers should be actively monitored in the same way as those contacts with high-risk exposure. Casual exposure would be something like if a person is in contact with a case before he or she becomes symptomatic. And that person is not considered to have an exposure where monitoring is required. Another example would be a person who is not in close contact with a symptomatic case, passing in a corridor at a distance, and that person is not considered to have an exposure where monitoring is required. However, such persons may have concerns, and their concerns are relevant to them. So they need to be supported and given information and advice. Identification of contacts. In this country, the most likely contact that we're going to have are people that are returning humanitarian care workers. We will have those. And that's the most likely contact that we will see in this country. There's a possibility if we have a case in the country, then there may be contacts of the case in the acute hospital setting. The most likely, and this is what we're hoping to train and prepare for, is those contacts would be in a planned way. So somebody who might be a potential case would go through to the hospital and would be seen in the designated area in the hospital in a planned way. In that instance, it would be only healthcare workers who would be contacts. However, in the unlikely event, but possible event, that there is an unplanned visit by a case or a person who eventually becomes a case, this could be in the emergency department, but there are other places where people may initially present in the hospital. It may be the MAU, etc. In this instance, there would be a number of other people in contact besides healthcare workers. They might be other patients and their families or friends. And finally, there will be cases in the community or contacts of the case in the community. They could be household contacts, work contacts, etc. So, a risk assessment of contacts. Every person in potential contact with a symptomatic EVD case or their blood or body fluids will have a detailed risk assessment carried out to decide which category of exposure they should be assigned. This could be a high-risk exposure, low-risk exposure, or occupational healthcare exposure. And others are considered not to have a relevant exposure. Who carries out the monitoring of contacts? Each contact will be given a pack, a letter, information, and if necessary, to monitor. In general, the following departments will carry out the daily monitoring of contacts. These, for hospital inpatient contacts, it would be infection prevention control. For occupational healthcare contacts, it would be occupational health. And for community contacts, including if there was an inpatient contact who is eventually discharged and now in the community, public health will carry out the contact tracing. They will also do the contact tracing for returned humanitarian care workers. Public health will oversee this monitoring and collect the relevant data, and contact tracing will be carried out under the auspices of the outbreak control team if there's a case in Ireland and if these are contacts of this case. So just something about the monitoring of various categories of exposure contacts. So contacts with a high-risk exposure, they will be asked to carry out active daily monitoring for symptoms and or fever for 21 days from their last exposure. This means they will take their temperature twice daily and they will report to the relevant department once daily or immediately if they become symptomatic. They must remain reachable for active monitoring. That is, they must discuss with their public health or occupational health if they're travelling within the Republic of Ireland and advise of the location to enable continuation of active daily monitoring and to provide support to access health care if they become symptomatic or is required. For contacts with high risk exposure, they would be asked not to travel outside the Republic of Ireland. We've looked at those healthcare workers with occupational exposure, where that exposure is high risk. So this would be something like somebody who attended a patient without PPE, or where there was a breach in PPE, such as a needle stick injury. It's very similar to those with a high risk exposure. It's active daily monitoring for 21 days and for themselves. They're to ring in daily and they're to ring immediately. If they become symptomatic, they must remain reachable with active monitoring within and discuss where they're going with the Republic of Ireland to make sure that we can continue that active monitoring and so that they can get access to healthcare if necessary, and no travel outside the Republic of Ireland. For those with low risk exposure, they will be asked to self-monitor twice daily and to for 21 days from the last exposure. If they become symptomatic, they're to report immediately to their relevant department. They're to remain reachable during the monitoring period. Generally, no travel restrictions, but this should be assessed on a case-by-case basis. But those with occupational low-risk exposure, active daily monitoring, as we said before, for symptoms for 21 days from the last exposure. So they take the temperature twice daily and they have to phone through to the relevant department once daily or immediately if they become symptomatic. They must remain reachable for active monitoring. They must discuss with their occupational health or public health if they're travelling, just in order that we can continue the active daily monitoring. No travel restrictions generally, but this needs to be assessed on a case-by-case basis. This is one of the questions we get often: what will be the restrictions for work and social activities? And these restrictions may change. Non-healthcare workers with high-risk exposure, no restrictions generally. Healthcare workers with a high-risk exposure, generally no restriction in social activity. They can attend office-based work with no clinical care or work in patient care areas, and for others, no restriction generally. Other relevant information: no contact to give blood donation for at least 2 months after last exposure, and the use of avoid the use of antipyretics. Trigger for assessment is a fever of 37.5 or greater, or any symptoms of Ebola. What to do then? If they become symptomatic, immediately self-isolate and immediately contact the relevant monitoring department. Arrangements will be made for the contact to be assessed in the acute hospital. This person is then a person under investigation. Should that person found subsequently not be found to have Ebola, they will continue to be monitored up to 21 days after the last exposure. Finally, I just wanted to say that we need, if we do get a case in Ireland, we need to balance, I suppose, the issue of supporting contacts who may have their own concerns, but we also need to have evidence-based public health measures that will protect the public. Thank you.